Hello, and thank you so much for joining me to my presentation on bystander CPR, past, present, and future. My name is Aditya Shekhar, and thanks again for joining me. I have no relevant conflicts of interest to declare. Below are the learning objectives for this session. We will be outlining the importance of bystander CPR in the chain of survival. I will provide a broad overview of the history of bystander CPR, and I will describe disparities present in bystander CPR before concluding with a discussion on 5 novel outreach strategies that may improve bystander CPR in your community. Below is my outline. First, we'll start off with some introductions, then we'll talk about the history of bystander CPR, move on to discussing the physiology of bystander CPR, talk about disparities in bystander CPR, as well as concluding on the future directions of improving bystander CPR in your community. With that, let's start off with the history and physiology of CPR. CPR was first described and published, or modern-day CPR was first described in July 9th, 1960 in the Journal of the American Medical Association. On the right-hand side of this slide, you can see a figure from that first publication. And you can see that many of the aspects that we think about CPR today were first described in this paper, and not much has changed when it comes to CPR. There was some early research on the idea of CPR not necessarily being performed by medical professionals and the idea of CPR being performed by bystanders. And this idea had a lot of success because bystanders were able to intervene much before medical professionals could. Here's a publication taken from the journal Circulation in 1977. And on the right-hand side, we have an editor's note from that early publication. I will just read a quick section from that. First, the increasing number of anecdotal reports of bystander or layperson CPR saving lives is to be welcomed. And another cool line from that editor's note that I really like is, the only way we will ever have sufficient medical care in this country is by the more intelligent use of medical resources by people interested enough in their own health to become educated by it. So CPR was first described in the 1960s, and then in the years following, we had this shift from CPR only being performed by medical professionals to the idea that CPR can and should be performed by everyone out there. But let's understand why exactly CPR is such a perfect bystander intervention. On this slide, I've outlined what I believe are 4 key factors when considering a bystander intervention. First, the bystander intervention has to be time sensitive. What this means is that the intervention should be best deployed often before professional help can arrive. This can be like performing the Heimlich maneuver to someone who's choking. It has to be easy to learn and perform. There has to be a limited potential for error if performed incorrectly, and it has to be life-saving. And then oftentimes this idea of a bystander intervention being life-saving and having a limited potential for error really go hand in hand. The benefits of performing the intervention have to outweigh any of the risks associated with the intervention. And as a thought experiment, we can sort of compare CPR with one of the most common surgical procedures performed, an appendectomy. CPR, I don't think anybody would disagree, is life-saving and time-sensitive, and it's relatively easy to learn and perform, and there's limited potential for error, especially when considering the benefits associated with CPR. By contrast with an appendectomy, things are a little bit different. Appendectomies are certainly life-saving, but they're not quite as time-sensitive as CPR. CPR, in order to be most effective, has to be initiated seconds after a cardiac arrest begins. But with an appendectomy, you have a window up to a few hours for when an appendectomy needs to be performed. Appendectomies are not easy to learn and perform, and there's unfortunately not a limited potential for error. And this is why appendectomies are most often and almost always performed in operating theaters of hospitals, whereas CPR can be performed almost anywhere. Now let's discuss the physiology of CPR. When a cardiac arrest begins, the heart is unable to pump blood throughout the body, and metabolically demanding organs are starved of oxygen. If CPR is not provided, these metabolically demanding organs suffer irreversible injury, and ultimately there's a failure to resuscitate, even if advanced life support arrives in a timely fashion. If CPR is performed timely, however, CPR is capable of supplying blood to metabolically demanding organs, and this leads to a reduced risk of irreversible injury, and then finally an increased likelihood of ROSC. And this is why bystander CPR is one of the most supported interventions in all of the medical literature. In the last slide, we talked a lot about metabolically demanding organs, but what exactly am I referring to when I mean metabolically demanding organs? And I think the most important stakeholder in this conversation is really the brain. And so the brain is the key when it comes to bystander CPR because irreversible injury to the brain can happen before EMS can arrive. And bystander CPR decreases what we call no flow time, or the time when cardiac arrest begins and the brain is starved of oxygen, and when CPR is initiated and the brain is semi or entirely perfused by CPR. So bystander CPR, in taking this into consideration, may actually be more about protecting the brain than actually restarting the heart. And if we look throughout the literature, we can see this shift. This idea of neuroprotection after cardiac arrest, or neurologic survival, have become commonly used throughout the literature. And some have even advocated for switching cardiopulmonary resuscitation, or CPR, to cardiocerebral resuscitation, CCR, to reflect the importance of the brain in CPR and in cardiac arrest outcomes. So now that we've discussed the physiology and history of CPR, let's talk about some disparities with bystander CPR. And the main takeaway from this section is that not everyone receives CPR, and that when we think about who is and isn't receiving CPR, predictable patterns and trends can emerge. So one of the earliest instances of disparities in bystander CPR is the idea of racial and ethnic disparities in bystander CPR. There were early reports coming out of Chicago and Memphis that found that non-white individuals were receiving bystander CPR at less frequent rates. And these came out in the early 90s, but these trends have remained surprisingly persistent. A meta-analysis published in 2014, looking at over 20 different studies of bystander CPR, found that black patients are less likely to receive bystander CPR than white patients. And even analyses published in 2020, 2021, and 2022 show that these disparities in bystander CPR across race and ethnicity tragically persist. We can zoom out to the neighborhood level and find neighborhood disparities in bystander CPR. There have been long-standing accounts in the literature that show that low socioeconomic status, as well as predominantly non-white percentage in a neighborhood, are associated with reduced rates of bystander CPR. On the other hand, predominantly white and predominantly high-income socioeconomic status is associated with increased rates of bystander CPR. And this has been shown throughout many communities across the United States, as well as globally. We can also explain some of these disparities with disparities in CPR training. So there's been a lot of literature examining who actually is receiving CPR training. And the unfortunate fact is that the white patients, white individuals and individuals of high socioeconomic status are far more likely to receive CPR training than non-white individuals and individuals from low socioeconomic backgrounds. So this may represent an ideal public health intervention for improving bystander CPR, and that might involve increasing or targeting CPR training specifically to communities that may have a high degree of non-white individuals and may not be high socioeconomic status. We can also look at bystander CPR on the basis of sex. Men are predominantly more likely, across multiple studies and across multiple countries, to receive bystander CPR when compared to women. We can also look at disparities based on cardiac arrest etiology. In this study, we looked at several different causes of cardiac arrest, and we found that individuals who had traumatic arrests or arrests related to trauma or exsanguination were the least likely to receive bystander CPR. One reason why this might be the case is that individuals may be hesitant to perform CPR on victims of traumatic injury because out of a fear of a lack of isolation from body substances or a lack of scene safety. So that's something to consider, that it's not just demographic disparities, it's also the circumstances surrounding the cardiac arrest, and that affects bystander CPR. We can also talk about transnational disparities in bystander CPR. So one of the earliest accounts of this came from the Pan-Asian Resuscitation Outcome Study, or PARO study, which was published a few years ago. And what they looked at was cardiac arrest incidence and outcomes across 7 different countries. And they found that bystander CPR rates ranged from 10.5% all the way to 40%, suggesting wide disparities, even within a single region, of the rate of bystander CPR. On the right-hand side, this is an analysis that we performed where we looked at 29 different studies that examined 35 communities, and we found that bystander CPR was actually strongly correlated with GDP per capita. On the vertical axis, we have rates of bystander CPR plotted, and on the horizontal axis, we have GDP per capita. And what we found is a strong association between GDP per capita and rates of bystander CPR. So in countries and regions where GDP per capita is low, rates of bystander CPR were also low. And in countries where there's high GDP per capita, there were increases in the rates of bystander CPR. So that might be one way to sort of wrestle with transnational disparities in bystander CPR. A final disparity I think worth mentioning is disparities due to COVID-19. Early on in the pandemic, there were concerns that individuals would be hesitant to perform CPR on cardiac arrest victims out of fear of potentially being exposed to or contracting COVID-19. And unfortunately, the data suggests these fears came true. This study looked at the first 6 months of the COVID-19 pandemic and found dramatic decreases in the rate that bystander CPR was provided to victims of out-of-hospital cardiac arrest, ranging from about 7 or 8% all the way up to 10% decreases in the rates of bystander CPR. So now that we've discussed disparities in bystander CPR, we can talk about novel strategies capable of improving bystander CPR potentially in your communities. The first is the idea of dispatcher-assisted CPR. And what this basically involves is if somebody calls 911, the dispatcher is actually able to walk them through how to perform CPR. And I think one of the coolest studies and a real testament to the effectiveness of dispatcher-assisted CPR is this study that was published in Circulation on the left-hand side that showed that individuals who received dispatcher-assisted CPR actually performed CPR at equivalent performance to individuals who had actually received previous training, showing that dispatcher-assisted CPR is capable of teaching people how to perform CPR in really time-sensitive situations, and they're able to do so successfully. Looking at 12 years of data in Seattle, the study in the middle found improved survival as a result of dispatcher-assisted CPR. And then on the right-hand side, we can see what the next step to dispatcher-assisted CPR might be, and that's even the idea of video being integrated into dispatcher-assisted CPR. The idea being if I call with a smartphone, perhaps a dispatcher texts me a link to a video showing me how to perform CPR, and I can use that video in my resuscitation of a cardiac arrest victim. Another strategy that could potentially improve bystander CPR is the idea of public testimonies to CPR effectiveness. There have been a number of high-profile individuals who have suffered a cardiac arrest, including soccer player Christian Eriksen, soccer player Fabrice Muamba, and then golf pundit Bernard Gallagher, all of whom have now become vocal advocates for CPR training globally as a result of their cardiac arrest. So the idea of seeing a famous celebrity suffer a cardiac arrest and then being successfully resuscitated may be one strategy for improving bystander CPR, and it certainly helps when the individuals who suffered a cardiac arrest and were successfully resuscitated have now become vocal advocates for the use of CPR as well as CPR training. Another really cool idea is this idea of CPR kiosks. These are placed in high-traffic areas like airports or convention centers or sporting events, and they can basically teach individuals how to perform CPR relatively easily. So there's a feedback mannequin as well as a screen. So the screen shows you how to perform CPR, and you can actually perform CPR on a mannequin contained within the kiosk, and it'll actually guide you on how to perform CPR, and it'll actually tell you how well you're doing. And in the middle, you can see a map of where some of the CPR kiosks are located, but on the right-hand side, you can see that CPR kiosks can actually be portable, which means that they can actually travel to music festivals or state fairs, areas where there's a high traffic of individuals, and they can teach CPR to a number of people in relatively quick amount of time. So that's something that I'm really excited to see, and I hope there's more of that in the future. Another thing to think about is the idea of CPR in movies and TV shows. On the left-hand side, I have probably one of the most iconic, or at least in my opinion, one of the most iconic scenes from television in probably the last 20 years, and this comes from The Office, where Michael Scott and the rest of the Office crew are learning how to perform CPR. But I think this scene, in addition to being absolutely hilarious, has a lot of relevance to the work that we do because there are several accounts of individuals who are actually able to successfully perform CPR on cardiac arrest victims based on what they learned from The Office. And when we look at this, it sort of emphasizes that people are learning from what they see on TV and film, but that really sets up a really high burden. And for those for whom much is given, much is expected, there's some unfortunate instances where CPR is not necessarily portrayed super accurately in movies and TV shows. There have been several studies that have looked at the accuracy of CPR portrayals in TV and film and have found that several titles actually come up short with the accuracy. And I think this really is interesting when held in context of the idea that people are watching and learning from what they see on TV. So it really gives a moral imperative to the TV and film industry to adequately and accurately portray CPR because people are watching, and more importantly, people are putting into practice what they see on TV. A final strategy used to improve CPR outcomes and bystander CPR is the idea of CPR by dispatch to volunteers. The idea being you download a smartphone application and are notified when there's a cardiac arrest in your vicinity, and you can arrive on the scene of the cardiac arrest before professional help arrives. But I sort of am not fully convinced by these. I have sort of four main ethical concerns. Number one, there's a question of verifying the competency of individuals on these platforms. So for instance, a study in the United States actually found that not everyone notified of a cardiac arrest was actually CPR trained. There's a question of liability. If an incorrect or dangerous intervention is performed, who's held responsible? Good Samaritan laws may not apply because some have argued that by joining these apps, you're consenting to be notified of a cardiac arrest. You transition from being a bystander to actually becoming a medical professional. So there's unanswered questions about liability and who's responsible. There's also questions about consent and privacy, as well as questions about protection of rescuers. What mechanisms protect rescuers if they're hurt or killed as a result of responding to a cardiac arrest on this platform? So this sets up to my final takeaway points. Number one, professional help may not always arrive before irreversible injury. Thus, CPR by bystanders dramatically helps increase survival. Second, there are disparities in bystander CPR across racial and ethnic, socioeconomic, as well as international lines. And then finally, there are several novel strategies capable of improving bystander CPR, including dispatcher-assisted CPR, CPR kiosks, CPR being portrayed in TVs and films accurately, and then finally, the idea of public testimonies to CPR, as well as celebrities becoming advocates for CPR training. Thank you so much for your attention, and together we can improve cardiac arrest survival. I've left my contact information at the top left-hand corner of this slide, and you are more than welcome to contact me anytime. Thank you so much for your attention, and I sure hope you enjoyed my presentation.